Hello everyone, it's Hunter Hicks. Today we're going to look at vertigo, a very common symptom that a lot of our patients can have. Now when we look at the inner ear, we know all this is kind of called our bony labyrinth. Okay? We know we have our semicircular canals and our cochlea. Now our semicircular canals help with balance, cochlea is going to help us with hearing. The thing that connects the two is the vestibule. In the vestibule, we have different kind of things that help us with balance as well. Now somewhere in here, we usually have issues with our balance. Now we also have our vestibular cochlear nerve as well, which we know is cranial nerve 8, which can also cause issues with vertigo. Now vertigo is broken down into peripheral and central causes. Peripheral is more what we're going to call it, or talk about today. Central can be issues with the cerebellum and the brainstem, like multiple sclerosis or a posterior stroke. The biggest thing with vertigo, though it can usually be a more common cause, is we want to always make sure it's not a medical emergency. Because there are things that can cause vertigo that if we don't do a very good neurological assessment on our patient, we might miss something. So let's talk about one of the more common causes of our peripheral vertigo, which is our benign paroxysmal positional vertigo, commonly called BPPV. What happens here is we have these calcium crystals, and they get out of what we call the urticle, which we find in the vestibule, and it gets stuck in our semicircular canals. Now we know we have 3 different semicircular canals. The most common type of BPPV is when these crystals, these calcium carbonate crystals, get stuck in the posterior canal. Now this can happen really with a lot of patients, very common to see. And it's usually just benign, meaning whatever might cause it. Sometimes it's trauma. A lot of different things. Sometimes people are just predispositioned to having this. Maybe they have a history of migraines, whatever it might be. The calcium crystals are causing the issue. Remember, inside our semicircular canals is fluid. As we move, the fluid moves with us. Therefore, we get these changes in our position. When we have a crystal just floating around in there, our body thinks we're changing positions, right? Well, that's what gives these patients these vertigo, is that they think that the body, the vestibular and the inner ear thinks we're moving because this crystal is kind of bouncing around in there, and therefore it gives us this idea of vertigo. So when we look at subjective or subjective with these patients, now subjectively, these types of vertigo episodes are usually brought on by positional changes, meaning they're not so much random. They can usually be brought on by getting out of bed, moving your head very fast, something like that. And then they get the sense of the room is spinning. They might get nausea, they might get pallor, they might get sweaty, stuff like that. They also will get usually nystagmus, which we're going to talk about here in a second. Objectively, when we diagnose these patients, and sorry, I should add that these episodes of vertigo are usually lasting shorter than 2 minutes, right? So they're usually pretty self-limiting, which is going to be a good diagnostic thing when we look at other causes of vertigo today. The Dix-Hallpike maneuver is a maneuver we can do to help diagnose BPPV, more specifically posterior BPPV, the most common type. What we do is have the patient sitting on the exam table. We turn their head about 45 degrees, and then we bring them back to a supine position. But we don't let their head rest. We usually keep it off the bed, usually a pillow, or some people let it kind of lay off the table. By eliciting this response, we look for nystagmus. The type of nystagmus that we're going to diagnose, sometimes people have rotary or they're going to be kind of moving in a circle, or they're going to have the upward beating nystagmus. So we can try this on both sides, trying to figure out really what ear we're dealing with. Now, if this doesn't work, we can always do the supine head roll, where we bring them and then we kind of turn their head left or right. That we're looking for a vertical nystagmus, and this is for our lateral BPPV. But again, the Dix-Hallpike for posterior, one of the more common we're going to see. Now, if that works, the Dix-Hallpike maneuver, we can use some of these canalith repositioning procedures, which we know are, we're really talking about how do we reposition that calcium crystal back to the vestibular where we want it. So these CPRs really we should only be doing, right, if we know we have a diagnostic of BPPV. What we're going to do is we're going to have the patient lay their head back to about 45 degrees. And the biggest thing is you want them to hold that, right? Because they want to hold for about 2 minutes because we need time for that crystal to go back to position. Then we'll turn their head 90 degrees, therefore moving the crystal. And then we'll actually have them lay on their side and move their head down towards the bed. The biggest thing is you need to hold these positions because it gives time for that crystal to set back to where we want it to set back to, back into the vestibular. Now, this can cause nausea and vomiting and stuff like that, so we can give them vestibular suppressants like antihistamines or anticholinergics while we're doing this. I should make an important note that usually patients that have this diagnosis of vertigo, they've already tried, maybe they haven't, maybe they're getting them prescribed, they've already tried some of these vestibular suppressants like antihistamines. Those don't usually work very well in this type of vertigo. Really what they need is the Epley maneuver, which we just talked about, or these CPRs, these repositioning maneuvers, to see if we can help them to get the crystal back to where we want it. Next type of vertigo is Meneirs disease. Now, this disease usually happens in patients usually in their 40s and 60s. It's uncommon to happen when they're very young, uncommon to happen when they're very old. And the idea here is our endolymph, or that fluid in the inner ear, there's just excessive amount of it. Now, some of the common signs and symptoms we'll see with Meneirs disease is things like the vertigo comes on more randomly, it's not usually positional, and it lasts a lot longer than BPPV. The other things that make it different than that is you usually have tinnitus and some degree of ear fullness, and also some degree of sensory neural hearing loss. Really, those last three things are things we don't see with BPPV. Outside of that, Meneirs sometimes is caused by stress, caused by high alcohol intake, caffeine intake, and salt intake. All things that we can help in the diet of these patients to maybe help decrease our chances of Meneirs disease. Now, when we look at subjective and objective, we kind of talk about this, but the vertigo is usually random, lasting a while, and they will have the nausea, pallor, all that stuff. They can have sweating, all those things can come with it. Objectively, it's hard, right? How do we diagnose Meneirs disease? Well, the biggest thing is we want to make sure it's not any other cause of vertigo, right? Meneirs disease looks a lot like some of our other causes of vertigo, which we're going to talk about, like labyrinthitis, acoustic neuroma, and even some of our central causes of vertigo. So we just want to exclude everything else and then land usually here on Meneirs disease. When we look at treatment, sometimes just having the patient close their eyes during an acute episode and just try and relax, okay? Other things like our vestibular suppressants, so our antihistamines, again, that's our meclizine, Benadryl, anything like that. These are our type 1 antihistamines or whatever we're talking about here. Those are helpful, but we got to make it very, very apparent to these patients. These viral suppressants are only used as needed, right? They should not be used prophylactically. You shouldn't take them in hopes that it'll decrease the chances of a vertigo episode happening. Because if they take these around the clock, and especially if they take these longer than 3 days, they might actually increase their risk of vertigo. Because remember, we're suppressing, right? We're suppressing the vestibular, response basically to vertigo. If we suppress that enough, we actually increase our risk because we're suppressing that central response. We actually might increase our risk for it. So not longer than 3 days and only as needed. Now, again, with Meneirs disease, a big thing we want to make sure it's not is an acoustic neuroma, which is usually a benign tumor that's going to push on our vestibular cochlear nerve, sometimes the facial nerve as well. It actually happens around the same age, and it kind of can have the same types of symptoms. The tinnitus, they can have sensory neural hearing loss, usually more progressive with acoustic neuroma, so it's getting worse. We worry about that. And we also really worry about it in patients that have neurofibromatosis type 2, and they also sometimes will have other signs and symptoms. If you're doing a good neurological exam with these patients, they might have ataxia, which we know we can see with them trying to turn when they're walking, assessing their gait. We can see it with the heel to shin test. We can see it with the nose to finger test. All those things, we worry about ataxia. Also facial involvement, so facial numbness and stuff like that, because we might have facial or cranial nerve 7 or the facial nerve involvement. So again, with Meneirs disease or any of these types of vertigo, we want to make sure it's not a medical emergency. Right? For an acoustic neuroma, they would then go for diagnostics, MRI, whatever have you, to make sure we do not have that. Last but not least is vestibular neuritis and labyrinthitis. Now these two usually are spoke about together, but they are a little bit different. Now both of these are usually a viral cause, sometimes herpes zoster, measles, mumps, polio, stuff like that. Usually causes inflammation to cranial nerve 8, the vestibular cochlear nerve. Now the major difference here, both are going to cause vertigo, but labyrinthitis usually have more of the sensory neural hearing loss, whereas vestibular neuritis, you will not get that as much. But these patients usually come with more of a viral etiology, kind of like our otitis media patients. We know they can have a degree of vertigo. These patients will have vertigo, and they can also have that degree of a viral cause. Now, treatment for these patients, again, are suppressants are going to be helpful. The scary thing sometimes about these types of vertigo with these patients is they can last a long time, sometimes up to 3 weeks. So it's really watching them, and if it's lasting longer and longer than that, you really want to be following up on them and making sure that you're getting good feedback and intervening if it's lasting too long, right? So vestibular suppressants can help here. Sometimes things like acyclovir, right? If we're worried about it being like a herpes cause or something like that, you might be able to actually treat one of the viruses. But in general, sometimes this is something people have to live with until we get that cause gone. In general, guys, these are just some of the causes of vertigo I wanted to cover today. There's a ton more, which we'll go in through another video. If you like this, give me a like, and I'll see you next time. Good luck.